Good morning and many thanks to the organizers of ESHG 2021. My name is Imaduddin Hassanin and I'm a PhD student in Institute for Genomics, Statistics and Bioinformatics, University of Bonn. And this morning I'm delighted to discuss with you the interplay of polygenic risk, high impact, monogenic variant and family history in breast and prostate cancer. And the monogenic trait is always caused by a mutation in one gene, while that is in contrast to the complex disorder that are associated with a large number of common variants or SNPs. Each of them have a small effect site that work together to influence the development of a disease. And to look at all of those common variants at once, now we use a polygenic risk score that is a weighted sum of trait associated alleles that we use to estimate an individual risk for a disease. However, the genetic contribution of many disorders is even more complex, and different type of genetic variation as those with minor effect, common variant, and high impact rare variant can play a role in developing the disease. And that the polygenic background coming from the common variant has a role in the general population and also in the carrier of high risk variant. And one example of that on a recently published paper by Kerry Tell that they looked at the impact of polygenic background on the risk of different diseases among monogenic variant. And you can see here the prevalence of breast cancer in monogenic mutation carrier with high polygenic risk scores has much more higher odd ratio than carriers with low polygenic risk scores, and that was in breast cancer and they included variant in BRCA1 and 2 mutation. So the aim of this analysis that I'm going to present here is to explore the interplay not only between the monogenic variant and the polygenic background, but also with the family history in breast and prostate cancer. And we asked if the polygenic risk scores has impact on breast and prostate cancers among carriers of monogenic variant or among individuals with a first degree family history or even among carriers with also family history. And here is an overview of the methods of this analysis, and I will talk in details in each step. I will start with breast cancer. Participants are from the UK Biobank, and we first identified the cases and controls and family history. And for variant annotation, I used ANOVAR, and polygenic risk scores was calculated using previously reported SNPs. And finally, statistical analysis was done using R. In breast cancer, participants here are from the UK Biobank, and we included individuals that have both genotype and exome sequencing data, and for that we use the latest release of more than 200,000 exome sequencing data from the UK Biobank, and we restrict the analysis for only females and only prevalent cases, and while all ethnicities were included. And the breast cancer diagnosis was based on the ICD codes and the self-reported cases. While for variant annotations, we use ANOVAR, and only variants in the protein coding region of BRCA1 and 2, JEC2, ATM, and PALP2 were included, and only variant with minor allele frequency less than 0.005 in any ethnic subpopulation of the NOMAD database were included. We exclude any annotated variant as synonymous or non-frame shift deletion or non-frame shift insertion, and we only included variants that are annotated as pathogenic or likely pathogenic. And then polygenic risk scores was calculated based on previously validated one using the p-link scoring function. And for analyzing the effect of polygenic risk scores in carrier of monogenic variant, we use the polygenic risk scores to categorize individual to non-high risk and high risk groups. And we use the top decile here as high polygenic risk score threshold as being identified by a previous study, which correspond to a lifetime risk of more than 30%. And also, you can see here there is a non-linear increase of breast cancer prevalence in here in the top decile, and we compare this high polygenic risk score group against the non-high polygenic risk score, which is the remainder of the population. And to see the impact of polygenic risk scores on the risk of mutation carriers, I calculated the odds ratio from a multivariate logistic regression model that was adjusted for age and first four principal components of ancestry. And of course, six here were not considered because only female were included in the breast cancer analysis. And non-carrier with non-high polygenic risk scores used as a reference, as it represents the most of the population. And then I estimated the cumulative incidence using Cox proportional hazard. Then we extended the same analysis exactly to prostate cancer. Participant also from the UK Biobank, and here we included only male cases and only the prevalent cases. We included the variant in coding region of BRCA1 to CHEK2, ATM, and HOXP13. And the polygenic risk scores was calculated from a previously reported 103 SNPs. And then I performed the same statistical analysis exactly. And those tables here report the characteristics of participants in breast cancer and prostate cancer. And for the first look, you can see that the group of carrier with high polygenic risk scores has the highest percentage of cases than other groups, and also had the highest percentage of family history of breast cancer. And you can see also that there are a higher percentage of family history in carriers and also in high polygenic risk scores more than the non-carrier and non-high polygenic risk scores. And here in prostate cancer, you can see the same trend exactly. The group of carrier with high polygenic risk scores has highest cases percentage and the highest family history percentage of prostate cancer. And you can see here that the polygenic risk scores strongly alter the incidence of breast cancer in monogenic mutation carriers. In the upper left side here in breast cancer, taking the non-carrier, non-high polygenic risk score as a reference, each of having a high polygenic risk scores or having a carrier has a comparable odd ratio. And carrier with slightly higher odd ratios than a high polygenic risk scores, while the group of carrier with high polygenic risk scores has the highest odd ratio here. The same trend exactly with the cumulative incidence here in the figure below. On the x-axis the age per year, and on the y-axis the cumulative incidence by age 70. And you can see that the carrier with high polygenic risk score group has the highest cumulative incidence and carrier with low polygenic risk scores. And for prostate cancer, on here, the right hand side, you can see that the polygenic risk scores alone has even an odd ratio higher than the carriers, and the carriers with high polygenic risk scores has the highest odd ratio. Then I did the same analysis exactly, but this time instead of using carrier and non-carrier, I used having a first degree family history or not having a family history. And by taking individuals that has negative family history and non-high polygenic risk scores, you can see that the polygenic risk scores alone or family history alone has a comparable odd ratio, and the group of having a family history and high polygenic risk scores has highest odd ratio. And again, that was the same trend exactly here in prostate cancer. Having a family history of prostate cancer with a high polygenic risk score was contributed to the highest odds ratio of prostate cancer. And then, okay, we asked what happens if an individual has both a first degree family history and a carrier of monogenic variant. Can the polygenic risk score still has a role on that? And for me, this figure summarizes all. Taking individuals with a negative family history and non-carrier and non-high polygenic risk scores as a reference, you can see that each of having a family history or being a monogenic variant carrier or having a high polygenic risk scores has at least partially independent effect, which is comparable to each other. And combining them increase the risk. And you can see that the carriers with positive family history and high polygenic risk scores has the highest odds ratio here in breast cancer and also in prostate cancer. To conclude, polygenic risk scores and family history and rare high risk variant act at least partially independently and cumulatively on the disease risk. And this analysis highlights the potential benefit of including the polygenic risk scores in the risk assessment and screening of familial breast and prostate cancer. With that, I would like to thank my mentors and colleagues in the Institute of Genomics, Statistics, and Bioinformatics in Bonn, and thank you for your attention.